going to transition, and part of that is a little bit of, what is that lily pad? And I think that lily pad could be something outside of directly emergency medicine, because we are so vulnerable as a hospital-based specialty that maybe we need to do something else. So one of my lily pads is a tiny house. I have an actual tiny house, so my overhead is extremely low. So that gives you more latitude. And then you can have alternative careers. You can start a direct care group. If you don't want to call it direct primary care, call it direct care, direct urgent care, whatever you want. You can escape a lot of these, and you can have alternative careers even with the IHS. So we're going to let a group of people give a little spiel about what they're doing, and then we'll host some breakout conferences right afterwards. So we'll start off with Dr. Ming Lin, and maybe we can just spotlight him for a second, and we'll go sequentially about a career with the IHS.
You're muted.
I'm not sure if you are. I think you're muted, Dr. Lin. Otherwise, I think you might be working on bringing up his presentation.
Hi, Mitch. Thank you very much. Let me see if I can get my screen on this time. Present. All right, can you guys see that?
Hello, my name is Dr. Ming Lin.
Oh, wait a minute. Why is that?
Supervisor for the Great Plains.
How come I'm recorded? Anyway, I'm a ER supervisor. Can you guys see the screen or no?
No.
It's not shared.
Not shared. Okay. Exit full screen. I don't know why it's not shared, but anyway. I guess I don't have a screen to share, but let me just go ahead and talk. So anyway, my name is Dr. Lin. I'm the emergency room supervisor for the Great Plains IHS. I basically travel throughout North and South Dakota. And my job is basically identifying problems, which is not very difficult in the IHS, and then trying to solve it. So one of the things about the IHS is we really lack ABEM physicians. Just an example, we only have about one ABEM doctor in 5 hospitals. We contract out a lot of doctors, but as far as the IHS is concerned, we only have one ABEM physician. So if you're looking for a job, IHS is the place to go. That being said, a lot of our locations are very, very, some of our patients live 90 minutes from the grocery store. So you can imagine what it's like for them to go to the hospital. Traveling there is another issue. Obviously, if you live in New York City or Los Angeles, it probably takes you about a day to get to the IHS hospital, because you have to fly into a small town like Rapid City or Bismarck, and then you have to drive a couple hours to get there. The population that we deal with is called the Lakota Indians. And when you think of the Lakotas, you think of the Great American West. When we expanded westward, there was a resistant group of indigenous population, Native Americans, that fought against us. And so when you think about teepees, that's a Lakota word for home. When you think about Sitting Bull, when you think about Crazy Horse, it's all Lakota. And so there's a lot of history in the Great Plains, and a lot of it's untouched, especially the reservation land. And I wish I could get my screen up so I can show you some pictures, but maybe next time.
We, Dr. Lin, if you finish a few minutes early, you can always switch back to you at the end if we have time.
What was that?
If you finish your talk right now a few minutes early and you get the pictures up later, we can always switch back at the end before the break.
All right. Anyway, so your options to work for the reservation, you have 3 options. One, you can work as a contract worker. And the problem with contract worker, obviously, is that your job is not secure. You're basically a contract worker, and at any point they can lose the contract. At any point, somebody can say, "Oh, we don't need you anymore," or you offended a patient, and you may no longer be working there. The pay generally as a contract worker is much better per hour. So there are some benefits. There's more flexibility in your schedule. The other option is to work for the hospital, the IHS itself. And there's definitely more due process in the situation. You will never get fired for speaking up for safety if you work for the IHS. The problem with working for the IHS is that our schedule is pretty rigid, and it's a very complicated thing. But generally, you have to work a certain amount of hours, and you have to work them at a certain time. And we're still trying to work on that to try to make some flexibility, because obviously emergency medicine is a 24/7 job, and it's kind of hard to try to fit our schedule into a 9-to-5 payroll. The benefits of working for the IHS is exactly that, the benefits. We have great health care benefits. We have retirement benefit. We have dental. We have vision. But on top of that, we also have sick leave. We have vacation time. We have paternity leave. And that's something that, I can't imagine as an emergency physician getting anywhere else. And the last thing I want to say is, as far as working for the IHS, is the Federal Tort Care Act. One of the things as a physician is that you will never get sued for malpractice if you work for the IHS. And that's because the government protects us in that situation. As a supervisor, I have to say, when I review a lot of applicants, I'm getting a lot of applicants who have dings in the National Practitioner Data Bank. And not because they've actually made a mistake in their malpractice, it's because the company decides to settle. And I'm finding that a lot of insurance companies now, especially when you work for a corporate management group, forces you to settle because it's a lot cheaper for them to settle than for you to continue with the malpractice case. Anyway, that's all I have to say for right now. I'm welcome any questions. And actually, there's a screen I want to share at some point. If you need a job, come look for me at ming.lin@ihs.gov.
Thanks, Dr. Lin. There's so everybody knows there's going to be breakout rooms, and I hope you're still around for that, Dr. Lin, afterwards, and we'll help you get set up with it. So if you have questions, want to do a deep dive, see all the images that Dr. Lin has, we'll do that next. And Dr. Galer, can you turn your camera on so we can spotlight you? And Dr. Lin, if you find the images and you want to get the shared screen, figure that out, we can swing back at the end too. All right, and sorry, there was a slight confusion. I was looking at the actual exhibit hall timing, but we'll move right on to Dr. Galer, and she will be hosting a panel along with hopefully Josh Umber if he's here, and Jeff Gold, or by herself at the break. Thanks, Dr. Galer.
Okay. Hi again, everybody. So I'll just sort of pick up where I left off before. I left that job that PRN job in corporate medicine. I had the latitude to do so because thankfully I was full-time employed with the Army still at that point. And I went back to, practicing military medicine. But I was really disheartened at that point because I knew I had to make a decision within the next couple of years about whether or not I was going to stay in the Army or not. I had always been planning to stay in the Army and make a full career out of it. But anyway, plans change, right? So once I decided I needed to get out of the Army, I also realized that, okay, working, in my city in one of these corporate hospitals was just not an ethical option for me. It was actually Mitch who introduced me to direct care. And to be honest, at first I had a lot of trepidation about it. As an ER doctor, the notion of switching into a primary care role or a general practitioner role, it's not something we think about. We generally think we don't like continuity of care, many of us. And anyway, I just decided to kind of look into it and see about it anyway. And what I realized is that, I actually found following up my patients pretty gratifying. I've been working in emergency rooms for now in some role or another for more than 20 years. And to be honest, the adrenaline wears off. I'm tired. I was really starting to struggle with the shift work and the flip-flopping and the depression and the weight gain. And, I saw myself going down this path where, I had this specialty that I just loved and had loved for so long, but it was becoming more and more incompatible with the rest of the healthy life that I wanted for myself. So anyway, I started to have this mindset change wherein I kind of realized that, this DPC model actually really does sort of speak to I think that cowboy streak that we all have. You know, we like kind of going rogue. The idea of, you know, running my own business really appealed to me. The idea of not having to answer to anyone except, you know, myself, my morality, and my patients really appealed to me. And the ability to be able to think outside the box, sort of as, you know, the premise of my business, really also sort of spoke to me. So, you know, long story short, you know, since opening my DPC practice, my quality of life has immensely improved. Sleeping at night, every night for an extended period of time just does wonders. I left the Army and immediately lost 30 pounds. It's just amazing. I can't tell you how much happier I am doing this. And I found that I really like having the time to sort of deep dive and go back into, you know, reading about things and learning about things and doing that really cerebral part of medicine that we often just don't have a lot of time for in the emergency room. So keep in mind that this is something that we can do. There's a very supportive DPC community out there that I really feel has welcomed me, even as an ER doc, with open arms. We are very, very versatile. And if I still have a minute, because I told Mitch I'd go fast, I'm just going to turn the camera around and kind of show you my practice so you can visualize it a little bit, in the hopes that maybe, you know, some of you will be a little bit more interested in coming to our panel. So here it is. Let's see if I could turn it around. All right, so here I am, just sort of sitting at my desk. I bring my dog to work frequently. That's awesome. I'm able to walk to work from my house. It's about a 10-minute walk, which is also awesome. I really wanted to be able to walk to work. This is where I sort of do my initial patient interviews. Try not to make you guys dizzy doing this. This is I call it my no waiting room, because nobody ever waits here. And I actually do really a lot of the same stuff I do in the ER here. I opted for, you know, having the ER stretchers. I have real monitors. You know, I have my little, you know, counter area. This is awesome. It's my eye wash. I wash out lacerations, that sort of thing. And then over here is my secondary room. And, you know, I run my own labs, do my own phlebotomy. I've got my you know, safety blanket right there. And really, I like it a lot. I get to do, I'm turning the camera back around now. You know, I do Regeneron infusions here. I've kept patients out of the ER with strokes. I get to do house calls and really help my community. You go on the Facebook group for the DPC docs, and people are converting, you know, AFib with RVR with PO meds, you know, in in the clinic. So it really is a good fit for me, even, you know, as an ER doctor, and it may be a really good option for other folks as well. So just open your minds to it, and if you're interested in more information, join our panel. That's all.
That's amazing, Dr. Galer. Yes, Dr. Galer and I guess we met for the first time at a DPC conference. And I had no idea that she was really going to go like all in, and I think it's awesome. So keeping patients out of the ER is like, I mean, she's been open for like 2 months, and it's been incredible with those stories. You know, a patient that had a missed stroke and didn't go to the ER because they were worried about costs, and, you know, was out of window and stuff, and she diagnosed it as an outpatient and saved the money with an MRI. Anyway, I will jump off and introduce Dr. Mcleoud. I don't know if Dr. Tarang Patel is still here. We'll have Dr. Mcleoud talk about her panel, and I think Dr. Patel will be in there with her for sort of a question answer. Thanks a lot.
Hey, can you hear me okay? Yes? Okay. So that was amazing. Your practice looks great, and congratulations on that, and good luck. For a totally different side of things, I want to talk about some personal finance and self-care that really matters in terms of helping you sleep at night, providing not just that lily pad concepts, but a launch pad for you to have some financial freedom. So I want to discuss some ways that attendings can do that, that are less available to residents. And I'm talking about debt refinancing, using credit cards appropriately, and just the things that you need to put yourself in a position to be financially free. I'm not discussing tiny houses. I will leave that up to Mitch, but I do have some other things that I think are helpful, that have been helpful to me, and I think we don't discuss enough and aren't educated about. That's it. Hope to see you in room K soon.
Okay, yeah, we didn't even go into your time that's needed, so thanks. But Dr. Mcleod will have a full panel, and I think you have a presentation as well, right? So there's a more formal presentation in her talk, and this the reason I really wanted to include this in here is that there is no way that this is what Dr. Getchwich had mentioned. You're under the thumb if you don't have control of your finances, if you're dependent on these corporations. So one of these things is personal finance, just getting control of it somehow. So Dr. Mcleod's talk was a little take on, I think, what White Coat Investor has said about live like a resident, but sometimes that seems so daunting that people just close their eyes to personal finance as a whole and then don't get started with anything. So I think she's going to take a little bit more of a approachable approach to getting, to starting to dive into personal finance. And I do see Dr. Patel here. Since we have a couple minutes left, Dr. Patel, you want to say a couple of words because you're going to be in the same panel with Dr. Mcleod? And also, I'm just going to mention Paula Muto is here too. She does have a booth, and it was a little last minute, but if we have time, I'm going to fit her in for a 5-minute chat as well. I'm putting Tarang Patel on the spot. Let's actually move right ahead to John Hopkins, if he is available with his screen shared.
Can you hear me?
Awesome. Yes.
All right. Thanks, Mitch. Hey, everybody. I'm Dr. Jay Hopkins. I am a board certified emergency medicine physician, but got out of Drexel in 2010. Went through a Democratic group that really wasn't Democratic. It was pretty much a CMG that was just poised and looked like a Democratic group. And then went and worked for Team Health for a while in various locations as a firefighter before turning to my wife and saying, I just can't do this anymore. I'm either going to leave medicine or find my own pathway. And what I was able to do, was in my free time, I do what I call my Google MBA and learned the business side of medicine. Tried to learn, why we were just highly contracted labor and what was being billed in my name and how I could do something on my own and kind of release the shackles. Thought about direct primary care at that time. I, thought it might be a little bit risky for me, but I think it is a great, great model. And I, in fact, actually went to government payers, particularly Medicare and Medicare Advantage, after learning that there's 10,000 new Medicare beneficiaries every day in the United States. And quite frankly, thinking that the model of care that was being delivered to a lot of these folks in their homes and in nursing homes and skilled nursing facilities and non-skilled nursing facilities, there was a gap. There was a gap that we all see in the ER, and I built something to address that gap. So what I've built since 2016, I've been out of the ER since 2017, is a comprehensive care model based on Medicare billing. We've gone from 1 employee, myself, to 50 employees, and we cover 4 states. And really, my talk is just about an introduction into government payers. It took me a couple of years to learn this space, to learn how to even forecast financially. How does somebody look up reimbursement codes? How does somebody see what we're worth? But I think there's also extremely large opportunity for emergency physicians to enter the transitional care space, hospital discharges, high risk, and doing close follow-ups. And it's a national opportunity, not a local opportunity. I'm over in the Northeast in the Philadelphia marketplace, but there's like 80 million Medicare beneficiaries that don't want to be in the hospital, and they're just looking for good quality care. The other thing that Medicare allows for now is a lot of value-based incentives, which I'm not expecting people to know what that means, but I'm going to explain it at my talk. So it can be as formal as folks want. I did put together a presentation, or it can be, if it's a small group, just kind of getting into the nitty-gritty on how to start your own practice, how to get your own MPI, how to get a PTAN, how to pick a biller, where do I go from here? So join me in my meeting room if you like, and happy to talk about what I do and what we do and answer any questions.
All right, Dr. Hopkins, that's awesome. And yes, I I think initially, if people think your talk is just about, value-based care, Medicare billing, we all might want to, our eyes might glaze over because we hate hearing about billing. But this is what has allowed you to, take some independence. And this is, I love this as a juxtaposition to direct primary care, because as Dr. Hopkins mentioned, Medicare is actually pretty transparent. And go ahead if you have a different comment.
Yeah, no, you know what I find very consistent in the 65 and older space when you look at direct primary care to, senior care is direct primary care makes sense for the younger population. Those older than 65, they don't want to pay a penny out of pocket for their health care. So this is a way to, how do you work with that patient population that's on Medicare, but do it in an efficient way. And I think it's fairly lucrative, and you'll be able to engage patients more through Medicare because they don't have to pay anything out of pocket. So it's really, the talk is a step 1 through 10. How do you start? Where do you even begin? And it's more about, if I was back in my shoes in 2016, what would day 1 look like after going through a lot of trial and error for 5 years now.
And I'll have to, I feel like I hear the DPC docs on here. I don't know if they're internally screening, but they know they do have a significant number have older patients and over the age of 65, and including my grandfather, who just joined Dr. Gold's practice. And sometimes they realize that they can get really good care through DPC and then have the wraparound of Medicare. But yes, once they think that they already have Medicare, it's like, why would I pay for something else, is often that thought process. But one thing that goes through my head is that there's a good chance for marriage of these types of practices, which is right now, if you're an ER doctor and you want to stay working in the ER, you broadly have to stay opted into Medicare. There is a Medicare opt-out for emergencies. So if you're with a stable Democratic group that understands that, you can potentially still bill Medicare even if opted out and go all DPC. So Dr. Galer, who's already doing that, could theoretically go work in an ER and they could bill Medicare because it's an emergency every time, theoretically, in the ER. But I don't see most hospital billing departments or CMG billing departments working with that. You're a disposable commodity. So anyway, I see that as a possibility for a DPC doc who might want to do hybrid care and actually, good point, Megan. But as a hybrid doc who wants to stay working in the ER, but for me, for example, I might want to start taking some elderly patients, and billing Medicare might be the only way. So I think that'll work really well. Thanks for speaking there, John. We are right on time, so we're going to turn it over to Heather and Brad, Dr. Dreifuss and Dr. Hammerstedt. There we go.
Hey, everybody. So I'll start a little bit, Brad. I'm Heather Hammerstedt. I'm emergency medicine board certified. Also have other certifications in medical acupuncture and integrative nutrition coaching and lifestyle medicine. I also have a MPH in public health, studied international health policy. So lots of things for me to talk about different avenues that I've gone with this. First off is that Brad and I are on the executive team of Global Emergency Care, which is a nonprofit that I founded with a couple other emergency physicians in 2007. And we work in Uganda doing emergency medicine education and capacity development. And it's been a wild ride to figure out kind of what emergency medicine could look like in another country that just didn't have it at the time, and kind of help our stakeholders and partners there really grow that system. And then I also run a company called Holist, which does lifestyle medicine coaching around food and exercise, and most importantly, kind of using neuroplasticity tools to help people figure out how to really make sustainable health and wellness changes in the long term. So that's my roles. I think the reason that I'm excited to be on this panel is because I know people are struggling with our profession right now and are often looking for like side gigs or other things. And I just want to be clear that it's possible. It's really hard work. I think that we're super smart, resilient, efficient physicians, and that we have a lot of tools to get into advocacy or global health or running your own business. And I think that one of the things I want to talk about today with Brad on our panel will be about, how do you recognize what those skills are? How do you decide what you're passionate about? How do you take the best of what you do as an emergency physician and the thinking that you're capable of doing and really make an impact in a different way that could be helpful for your communities, but also, make you money so that you don't have to work shifts if you don't want to. So go ahead, Brad.
Yeah, thank you very much, Heather. So yeah, Heather and I have been working together a long time. This is a super exciting opportunity. So I don't think we've actually been on a panel together. But for me, it's been advocacy from a young age. And really it's been a super steep learning curve that's increased, I think, at every step of the way. And so I think as Heather's a fantastic coach and really wants to help us figure out where our place is, I have some insights on what are the constituent components to actually allow us to be successful in those spaces. And then how do we actually start making this move towards a model where we can actually potentially fund it, right? Terry was talking a little bit earlier about some of the impact investing, and we've been thinking about the same things for a long time in that regard, but it's not been part of the culture. And so how do we start thinking about honorable ways to not be in the position I'm in right now, actually, which is where I'm working 0.6 of an FTE, and I don't have another line of income because that's something still working out. So yeah, I want to be able to bridge these pieces, and I look forward to meeting with y'all. I'll kind of go through the organizations I work with and what's been learned through the process.
Thank you both. I think I'm gonna address Kate G, Dr. Gashwick's comment. I'm still probably mispronouncing your name there. But honestly, I just want to address that because maybe it's an elephant in the room. Torn about advocating for these new practice models to new physicians, to be honest. On the one hand, it is selling, or is it selling out our specialty again by allowing ourselves to be pushed out? On the other, it's short-sighted to not read the writing on the wall. Well, I think this gives all of us, I think any of these models give us more autonomy to speak out, because if you don't have the autonomy to speak out, what are you just going to self-flagellate by working for Envision Team Health and hating your life and then be part of those statistics of suicides? I don't think that's a viable option. So, I totally understand this, but this is why I've kind of curated this panel of people that I think are making a real big difference. And not to say that you can't just go start a Botox clinic or something. I mean, but that's happening, and people want to get switched. Got it. Thank you. People want to get out of medicine and will do anything. But I'm saying that how do we feel good about contributing to society? And then we have to acknowledge that ultimately people are going to still have real emergencies, even though I think we can get probably 70% of that or 80% of that out of the ER and still use us as emergency physicians to give better care to patients than they would get in the ER. But we have to acknowledge that real emergencies are going to happen, and people deserve a good emergency system, which is about what the rest of this conference is about. I just wanted to address that.
Yeah, sure. So can I add something to that? So I think also, at least for me, right, I still work clinically in emergency medicine, but knowing that I am like inspired and fulfilled by the other things that I'm doing makes me a better doctor in the emergency department. And it also like has made my brain bigger about the things that people need, whether that's in Uganda and me understanding kind of how emergency care is being built there, but also, the lifestyle things that people are coming to us with that I hear from people all the time that I've never thought about, right? They're overweight because, they had an alcoholic father who used to throw stuff around at dinner time, right? And so there are all these things that we don't, that I didn't understand. And so for me, at least, branching out has made emergency medicine a stronger field for me.
Amen.
Thanks, guys. That was awesome. Let me see who we had here next. I think.
Yeah, I hope to see you guys I think we're in room L or something like that. So
yes, you guys can check in the Kiko chat space. And I feel honestly torn because there's so many. I want to be in every one of these, honestly. And I know a little bit about all of them, but not enough about any of them. And that's why I'm really, really happy that these are recorded, because I will actually be going back and watching each of these, because they could really add to what we can do. Great. Thanks, guys. Dr. Ryan is a board member at the Direct Primary Care Alliance, and my DPC mentor, I guess I got a few, but my local DPC mentor, who has been incredible. Really, Chicago has very few DPC doctors in the city, and I did the same thing that Neer Patel did, which is, looking around for ones that really looked truly not corporate and like they were, doing it for the right reason. So that's Dr. Ryan, and she is, although we have DPC talks here, going to be talking more about what she's found in teaching as, I guess you can call it an alternative career, but teaching all of these lessons that we've been talking today to the future generation and making a career out of it. So thank you, Dr. Ryan.
Hi, everybody. I'm very happy to be able to talk to you guys today, surrounded by all you movers and shakers and rabble risers. My story, I'm originally from Ireland, from Northern Ireland, actually. So I grew up with an NHS healthcare system as a child, and then moved to the south of Ireland to do my medical school training right from high school, and did a 6-year program there. Worked there for a few years. Different healthcare system, some similarities to the NHS, but I came here then in my late 20s and did residency locally here in the Chicago area in family medicine. And so after residency, private practice for a few years, and having all that experience with the different healthcare systems in my past, found it very difficult to gel with the healthcare insurance system here. And then Obamacare really just cemented the fact that I didn't want to be in this kind of a medical system anymore. And I started my DPC practice in 2017, 4 years ago, and I've never looked back, and didn't really think that I had it in me either. I think a lot of you guys may think that, because you're ER docs, you're not really used to being outside on the outpatient clinic. I was in the outpatient clinic, but I didn't really have any experience running a business. And I just kind of, find myself some mentors before I met Dr. Lee, and help myself along. It's really not that hard. There are plenty of people that can help you do that. DPC opened a lot of doors for me. And the first thing that happened was I started to precept medical students. One of the local lecturers, one of the heads of department at one of the local med schools, Midwestern Osteopathic School, found out about my clinic and said, we'd like our students to go through your clinic because it's different. We want them to see a different model. So I precepted for about a year or two, and then was asked to give a lecture on DPC in the family med rotation. I still do that every 8 weeks, and that's led to other lecturing. The clinical case scenarios, etc. I've built a bunch of different clinical lectures. And so last year, when March 2020 happened and we all went virtual, I was the med school faculty got together and said, we really need to have a telemedicine elective, because we realized that nobody on our faculty has any experience doing telemedicine except for me, Dr. Ryan. So they asked me to put something together, and of course, telemedicine would be a very difficult thing for me to speak about for 4 weeks, and I decided to build it into more of a telemedicine being one module. Let's talk about the healthcare system. Let's talk about the problems. Let's talk about health insurance. What does it mean? Let's talk about Obamacare. So I built a course last May, and it came across the dean's desk, and he called me in May and said, we need somebody to fill in for the whole entire third-year class in July 2020 because we can't send them to the hospitals. Can you take it? And I was like, of course. So I built this course. And I'm going to talk a little bit more about the course when in our breakout rooms. Actually, the students have been very receptive. So took the 200 third-year students in July, and now it has become a permanent part of the curriculum, which is an elective that the students can choose. So I have anywhere from 2 or 3 students a month to 15 to 20. And there is so much discussion. These students are dying for this information. They do not get it anywhere else. Their preceptors in the busy rotations don't have time to teach it to them. And they deserve to know what's happening, the stuff you guys are talking about at this conference. And so I try to make it as positive as possible and tell them that, medicine is still the best job in the world. But it's better when you're on the outside and you can control your environment. So even though a lot of them are not going to do primary care like me, a lot of them are not going to do direct primary care like me, I try to teach them, empower them to understand the system, understand what contracts are, understand non-competes, so that when they are prepared, when they go to residency and beyond, and they know that they should be planning that stuff too. So that all then led me to a position on the advisory board of the Direct Primary Care Alliance. And actually this weekend in LaGrange, Illinois, which is just outside Chicago, I'm hosting a small group conference for physicians who want to learn about direct primary care. And we do still have some slots open. I did put the flyer in the chat a few minutes ago. My email is dr for doctor, and then my full name, Clodagh, Clodagh, Ryan @gmail.com. If anybody wants to find out more about that. It's in-person, intimate. We usually have about 10 to 15 attendees, lots of time with 3 seasoned DPC docs with different kinds of practices. Dr. Schumacher has a full busy practice with lots of employer groups. Dr. Aliyah Gupta is a micro practice, no staff, started from scratch. I'm kind of somewhere in the middle with 2 part-time staff and now doing teaching on the side. So if anybody wants to find out about that, it would be a great great add-on to this conference. And if you would like to find out more about teaching and how to teach what you love at med school or even in residency, please join me in my breakout room. Thanks very much for listening.
Thanks, Dr. Ryan. This is awesome. I really think that this is, key for the continuity of this, because we've been talking about how we got to get this, word out to med students and residents, and Dr. Ryan's made a part of a career out of it. And I think that is what we do need to transition to at some point. So yeah, please join Dr. Ryan in that room, in the breakout room. And definitely if people are interested, I think the only, I don't want to call it downside, but your course is not virtual, right? So people would have to travel to Chicago if they want to do the.
We do not at this point have a virtual option. My tech skills did not allow me to do that. Some of them do actually. And with the last mastermind, which was a few weeks ago in Maine, run by Dr. Jack Forbush, he's the tech guru of our board, and he actually built, it is virtual, and they're just working on the video, the recordings from that. So that will be available for a reduced cost, I think, to view if anybody wants to do that. You would find that on the dpcalliance.org website. And I know it's not up yet. He's still just splicing and editing. So yeah, unfortunately, I don't have a virtual option.
No problem. I just wanted to make that clear in case people wanted to join. There's still a couple days to come out here, and I will be mooching on the dinners, I think, that yes. Or I might even join during the day, who knows. Actually definitely could use some of that. I mean, and as Dr. Hernan mentioned, the breakouts, oh man, I know I want to go to each of them. So, and if everybody doesn't have, I mean, obviously all the groups are not going to have all the participants. So know that I think everybody could get a lot out of each of these talks. So, and check out DPC Alliance as well. I think what I like about DPC Alliance is it's stayed pretty pure. Actually, Dr. Hammerstedt, I think, is pretty open that her physician is, I think it's Julie Gunther, who's the president or the head of DPC Alliance or outgoing.
Yeah, she is.
They've stayed pretty pure to the idea of what I love to say, scale autonomy. Like, let's not scale DPC into one medical with a bunch of venture capitalism, but let's scale autonomy and give the ability for each individual physician to do these, because it's daunting, right? Starting a business seems to be daunting. And if you have a bunch of student loans, then it's daunting, and we're not taught anything about it. So that's what I love about DPC Alliance as well. So let me introduce Dr. Paula Muto, who is a vascular surgeon. And at first, I completely ignored all of her requests to talk because I thought she just had another One Medical or Iora Health or something that, or Teladoc. And part of that's in the name. Dr. Muto has Uber Doc. And I would say it's probably similar to HPEC in its funding model. There's some angel investor physicians. And I love transparency, and that's a litmus test for anything that I am willing to embrace. And again, I'm not an investor in any of these things. I should mention that I don't have any investment in HPEC or UberDoc or anything here. I am technically the owner of Take Medicine Back PB LLC. It's a public benefit company, and I'm happy to go into what that is otherwise. But all of this has been volunteer myself, and all the physicians have been volunteering. But I wanted to introduce Dr. Muto because we met more recently. So this was kind of a last minute addition to the conference. and she has a booth. But as I mentioned, transparency is really the key for me. And I'll let Dr. Muto explain, and I'll jump in afterwards if there's anything she missed about what sort of I thought made this unique as compared to like a teledoc. And I think this is partially might be the bridge to getting emergency physicians who might want to test the waters, start their own direct care organization, and it can be complementary as well. So go ahead, Dr. Muto.
Thank you, Mitch. And first of all, I want to say I've been listening in and out of office hours and so forth, and I'm just I'm really impressed by what you put together. The passion amongst people, it's your profession's really coming together, and it's exciting. We all have to come together. So I'm a surgeon. I'm a general surgeon and a vascular surgeon. You can see my supersized poster behind me. I have been from a whole family of surgeons. My dad was a great surgeon, thoracic surgeon. He was in the ER all the time, in his pajamas half the time, because he was really good at what he did. My husband's a surgeon. He was the head of trauma at our local hospital, as well as chief of surgery. My brother's a surgeon, 2 uncles, orthopedics, all in Massachusetts for a collective century. So you kind of see where the genetics are. A few years ago, I really didn't like the system. I thought it was like kind of inconvenient to get an appointment booked. You had to get a referral, authorization. Patients used to bounce around a lot. So I said, maybe I could make it easier for a patient to see a surgeon. So what started off as just an appointment maker, push a button, use technology to have a patient get directly to a doctor without a referral, became this movement. Now, how do you get to a doctor without a referral? You go by cash, but do you set that price really high? No, you set a reasonable price. We just above Medicare to be legal, but below commercial insurance. What? We actually increased the access and lowered the price. Well, it made sense, right? You're getting a new patient in your office, and there's downstream revenue potentially from meeting a new patient. But it started off as 6 core surgical specialties. And then next thing you know, the DPC doctor said, why can't we be on your platform? And I'm like, why not? The psychiatrist said, why can't we be on your platform? I'm like, why not? And then the emergency room doctors came to us and said, well, what about us? And I'm like, well, you know, it's an in-office visit. But next thing you know, a telemedicine company came to us. The people who actually created the software, the original software for the space station, came to us and said, you're beautiful. I said, well, thank you, you're beautiful. He said, because we want telemedicine in the hands of end users. And your model is so clean because its patients are going into doctors' offices. Could we convert some of those doctors' offices into virtual offices? And I'm like, really? What is a specialist going to do with telemedicine? Now, this was way before COVID. And here I am with my poster behind me. And yes, what is a specialist going to do with telemedicine? So when an ER physician contacted me and said, why can't we be on your platform? So UberDoc became an appointment maker for in-person exam and telemedicine exam. And the ER physician said, well, why can't I? They said, you know, I'm really good at what I do. I've been doing ER for over 20 years. I can diagnose based on a history. I can really manage people. And there's so many people who can't get to us, especially now in COVID. They just can't, you know, and he was in like Alabama, in like a very rural area. And listening to him talk, I said, well, why not? Why can't we create urgent care? And after all, teledoc is a one-off phone call where a doctor gets $20. It's like UberDoc, the doctor is just working for the patient. Our model is entirely clean. You join UberDoc for free. Did I say that too loud? For free. That's how much I want to disrupt this system. The doctors join for free. We're just the transactor. We have patients on one side, doctors on the other, and we're the link. We're the technology link, and then we're the payment processor. Yes, we take the credit card. Stripe actually takes it, not even us, very securely, and it goes directly to the patient. So we've created a marketplace between patients and doctors through a transparent price. Our whole mission has always been access and price transparency. So now we're heading into this complete chaos, right? Medicine is chaos. One of our big local hospitals, and I've been listening to Team Health. Team Health also has anesthesiologists, and they've decimated the anesthesia departments. Leahy Clinic has no anesthesia right now. Did I say that too loud? They literally have no anesthesia. Somebody was told their emergency operation was booked for the end of October. So it's a major crisis, not just to ER physicians. PE has really destroyed anesthesia as well. So, and even in my hospital, I have to put in a request for weeks to get just an elective case on. It's crazy. But what we're seeing now, though, is that out of the embers, out of the ashes, something new has to emerge. And when I look at ER physicians and I say, you're really well trained, like there's no reason why I should at night, if I'm unsure where to go, to be able to connect with an emergency room physician virtually is fantastic. Not a $20 one-off, but an actual visit. And I think that there's a marketplace for this and that it is not quackery, because the teledoc versions are all insurance paid. You know, the teledoc is backed by Blue Cross Blue Shield. Amwell is backed by Aetna. I mean, these are all just insurance ploys. This is direct to consumer, patients paying doctor, fees are clean. It's transparent medicine. And speaking with Mitch, he has some really interesting ways where he can follow patients. So I think that, you know, that there's definitely a room for these new models of care. I definitely think telemedicine has to be part of everybody's practice. I don't think it has to replace your examining room. It just has to add another examining room to it. And I think for ER physicians starting off, if they are able to be, you know, put their name on an UberDoc list and see if they get a patient that they can connect to, they're already covered with their malpractice because they are ER physicians in the state that they have a license in. I think there's a lot of opportunity here. To me, it's a matter of like watching the consumer. And which gets to my last point. This is a direct to consumer world. We want to beat private equity, take the customers, take the business. We own the business. We do the business. They can't do it without us. So, but there's been a reluctance for doctors to kind of step to the forefront and say, hey, here I am, and this is my price. Because we've been convinced the price is unattainable. It's too high. It's not too high. It's finite. We know it's finite. The prices have been inflated. So anyway, so that's really excited to be here. Thank you, Mitch, for inviting me. And everybody can go by the booth. You kind of go through our little slide deck there. If there's any questions, you can reach out to me directly. My contact information is there. And I would love to be able to kind of like a pilot, merge forward and give the opportunity for doctors to step their toe into that direct pay world and also that virtual world.
So Dr. Muto, you know, we have like 2 minutes left. I think it's important. And I would love to ask you, because you have answered these questions to me. And so I think it would be great right here, because we, of course, if you Google your company, it says privately held finance status, venture capital backed. And
well, we're VC backed just to show that we're impressed, but our venture capital groups are 2 doctor venture capitalists they're very small, D4HI, Doctors for Healthcare Initiative and Global Health Impact Fund, both physician owned ventures.
And of course, we know that doesn't, that's not always protecting, because we have greedy physicians that have, you know, started ruining our thing. But what I wanted to ask you, and you have answered me before, is there are no non-competes or non-competes or restrictive covenants, right? And then what is the actual arrangement? There's the physician can set their price.
They can set their price. They can't set it below 150. We're not doing that.
It's not letting physicians devalue themselves.
No.
But you set the price. The physician can set the price, and then
physician sets the price. They join. They put as few as 1 appointment slot a week, and they appear in perpetuity. If they have a telemedicine platform they like, they can bring that address to the platform. If they want to use ours, we partner with VC. I see there's a question about VC is wonderful, and they do our telemedicine, so we can provide the telemedicine. And the malpractice, again, this is it's an independent model. We're not paying. You know, doctors come to our practice. We're an appointment maker, basically. That's all. A marketing page and an appointment maker. So the doctors are entirely independent, but there are a number of malpractice companies that actually kind of look at our network. We have 4,000 doctors across the country in every specialty now in every state. So it's a really interesting place. So we're kind of we're getting numbers, and so malpractice companies are interested in kind of talking to us about offering doctors lower, because telemedicine malpractice rates currently are very low. But really, our whole concept is about autonomy for the physician. We are just a tool. We are a platform. We're just providing a virtual examining room. We're a connection, and we're a marketing platform. We want to disrupt the system and bring a direct pay model into the marketplace, not just for the direct pay primary cares, but for the direct pay doctors, all of us. And employers are very interested in this model. And like I said, I think emergency doctors should not be working for Teladoc for $20 or HIMSS or Roe or all these other things, right? I think that's, you might as well go and make coffee at Dunkin' Donut if you're going to make $20.
And the key for me was that ultimately, if I see a patient through your platform, I can even recruit them into my practice.
They are your patient. We are not. That's one of the reasons why ventures don't like me, because I say I don't want a piece of X, Y, and Z. We want to be the front end, because if we have a seat in everybody's waiting room, we do just fine. And let me just tell you, UberDoc is about our mission. I have a very good day job, like all of you. We do this, as Mitch is volunteering. I volunteer for this. You know, we're not doing it for the $1 billion payout, but we're doing it to get a seat at the table. And everything we've heard means that you have to have dollar bills to get a seat at that table. But wouldn't it be nice to put those doctors at that table?
So we are at 1:30. Thanks so much for the introduction. And Jay, I'm as skeptical as you in general. Are they planning a big exit? We don't have to answer that right now, Dr. Muto. I don't think we actually have time for it.
Big exit? Oh, no. Laughing. Yes, we're $1 billion company. Yeah, I'm going to be a unicorn. Yeah, that's what I want to do. Now, this is the only thing people say to me is it could fail if the prices came down and the system became transparent. And I'm like, then I would have won anyways.
And honestly, what gives me some credit or some potential faith here is that if there are no restrictive covenants, if the company changes, we can't predict the future. Even HPEC could sell to Blackstone. Theoretically, it would ruin their credibility, which I think is one reason they wouldn't. But at the same time, HPEC gives us, we'd still own our data, so it wouldn't be that valuable to Blackstone. The other Megan mentions she doesn't see EM as a specialty.
So we have urgent care, because our platform is a 12-hour lockout. We do not want to take a patient out of your emergency room that needs an emergency room physician. We're all about great medicine here, right? You don't want somebody with a broken limb sitting at home. They need to go. That's an emergency. So we have a 12-hour lockout. So we have urgent care. And this concept of virtual urgent care is, I think, fascinating. And being able to partner with some of you guys and build it would be really wonderful.
Thanks, Dr. Muto. And I'm sorry, we're going right over right now, but yes, one thing I think we can also help as emergency physicians in real time is sometimes keeping other doctors helping keep their patients out of the ER. But that's separate. Let's break out right now, because I don't want to push into everybody else's breakout and workshop time. If your workshop sort of ends early, I would say get in touch with Diana Prince. And let us know, because if we have 2 workshops that are out early, we can probably switch and you can probably go to both. But I think that's it. We'll see you guys back here at 2:30, and that's when we will be jumping in for the rest of our panel and have some big closing discussions.